speaker this morning is Sandy Anderson. So let's, so I can.
Hello. Can you all hear me?
Yeah, we can hear you.
Okay, great. Well, first of all, I just want to say happy birthday, John. Sorry I can't be there in person. It was just bad timing because I already am in Barcelona at another meeting. But I'm sure you're going to have a great time, and it looked like a really nice schedule of speakers. So let me start. Okay. So I realize that I'm between you all and lunch, so I'm going to try and make this short and sweet. So what I wanted to talk to you a little bit today about is something that's kind of relatively new. And it's work that we've done that's really looking at the role of PARP inhibitors in ovarian cancer. And one of the big issues with PARP inhibitors is potentially toxic side effects. Let me just stop this, get rid of that. Thank you. So before I begin, I think most of you know about IMO, but just in case there's some people in the audience there that don't. So I run a department of integrative mathematical oncology, and we're very much a team science department. Everything we do is kind of driven by multiple PIs. So that means that the funding is always mixed between experimental and theoretical and clinical components or combinations of those two. And so that means that most of our science is either driven by data from experiments or data from the clinic, and we're always trying to think of ways to impact clinical decisions. So that really kind of puts the focus on what we're interested in firmly in translation. And so to this end, we've been running a workshop for the last 12 years, and we just had our 12th one focused on toxicity. So it's very pertinent to this specific talk that I'm about to give. And one thing I wanted to bring up again, if there's anybody who's not heard of the workshop, is that we fund 25 to 30 participants from all across the world to participate in this hands-on modeling workshop. And part of it's about really trying to bring new modelers into the field that want to think about how you can actually impact clinical translation. Okay, so let's talk about the real issue with clinical translation. So the biggest problem that we have, and this kind of generic graph that I'm showing here kind of represents a tumor burden timeline for almost every cancer. The timing is deliberately vague because it will vary significantly depending on the specific cancer. But loosely speaking, this is the sort of behavior we see across many cancers. So normally cancers aren't detected until they reach a certain size or a certain tumor burden. And at that diagnosis, first-line therapy is often something like chemotherapy or radiotherapy plus surgery. And that'll often mean that the tumor, the bulk of the tumor is gone and there's no evidence of disease. And that no evidence of disease can last anywhere from a few months to years. But often what happens is the disease comes back, and now there's this recurrent disease, and you treat often with the same first-line therapy, but it doesn't work as effectively, so they move on to a second-line therapy, and so on eventually to a third line of therapy. And now you've got something like multi-drug resistance. And one of the crucial things about these decisions about when you add your second line or your third line or your fourth line, whatever therapy is, that essentially you fail the previous treatment and then you switch to the next. And so that paradigm is something that we think should change because it's not working. It's definitely not working in metastatic disease. And so one of the things that we did in Moffitt was establish a new Centre for Evolutionary Therapy, and we started it about 7 years ago now. And it's myself, Bob Gattenby, and Jinsong Zhang who are co-directing that. And the purpose of this centre is twofold. One is to really bring mathematical modelling, evolutionary principles, and sort of personalized patient decisions to the fore, but the other is also a route for philanthropy. And so it's a way for us to get funding to actually pay for our clinical trials that are a little bit out of the box. And so you're probably asking, what are these evolutionary therapies? And so I've got a couple of little cartoons that help explain that. So this is just showed you is the kind of classic U-shaped dose response that you get when you give maximum tolerated dose strategies. You often get a very good initial response. Then sometimes it goes into kind of, below detection limit, no evidence of disease for a period of time. And unfortunately, the strategy is to continue to keep treating even past that. And then eventually what happens is the tumor population grows back. And so in this little cartoon at the bottom there, you can see a kind of heterogeneous tumor mass. If I could target every single sensitive cell there and only leave behind the resistant, then after that initial eradication, all I'm doing is just really letting this resistant population grow without competition. And so we often call this competitive release. So Bob Gatenby sort of came up with this distinct idea which really kind of emerged from how we deal with pest management when it comes to crops. And essentially the idea is to give the minimum effective dose instead. So we reduce the tumor burden, but we deliberately don't eradicate all of the sensitive cells. We leave some behind, and then we stop treatment. And when we stop treatment, what happens is the tumor will begin to grow back. Importantly, that growth is different between the sensitive and resistant fractions. And in fact, the sensitive cells will grow back quicker in the absence of drug than the resistant. And so now I can repeat this minimum effective dose, stop the treatment, and loop this process many, many times and potentially control the disease for longer. And of course, there's lots of assumptions based on that. Another therapy that we've been working on actively, and it's going after more of this sort of cure approach, and we call it extinction therapy in part because it's really sort of exploiting understanding from how, in ecology, extinctions occur. And so here the crucial thing is to really think about sequencing therapies in smart ways. And often what you want to do is come up with your first strike as your most effective strike that's going to push the tumor into this no evidence of disease, below detection limits sort of setting. And then think strategically about what your second, third, and fourth strike should be. And ideally, maybe you're picking those strikes in a smart way that says, escape from that first strike will make me more susceptible to the second, and escape from the second will make me more susceptible to the third. So you don't wait till failure of any one of these strikes. You deliberately switch as soon as you get some sort of response. But what's kind of interesting about this approach is that once you've had that initial strike, potentially you're trying to make decisions when there isn't any evidence of disease. So how do you know when you should switch and what the best strategy to switch is? So that's very much work in progress. So this brings me to the PARP inhibitor part of the story. And it's really, it has been quite a revolution in ovarian therapy. And so one of the things you probably don't know is that ovarian cancer is one of the it's the fifth deadliest cancer in women. And part of the reason why it's such a deadly cancer is because it's often late in terms of its diagnosis. And that means it's already pretty high stage. And so that makes it much harder to treat. Often it's quite responsive to initial therapy, and that's chemotherapy, but it almost inevitably recurs. And so that with less than 30% chance of 5-year survival. So on the right, you can see this kind of PARP inhibitor, standard approach. At least in the US, you get your chemotherapy, brings it down. Often they'll also have surgery, debulking surgery, and then they'll get the PARP inhibitor. And this can be delivered as a maintenance setting where they just now are going to be on this PARP inhibitor for several years, or it can be given as actually an effective treatment. And it's particularly important for BRCA mutant patients. And so what can happen, unfortunately, even with this approach, is that we can get almost within a short period of time, resistance emerging. So if you look at the left panel here, you can see this is from a real patient sample. One of the nice things about ovarian cancer is that you can get a blood marker called CA-125, which lets you basically gives you an estimate of the tumor burden, a bit like PSA. And so what you can see here is from a patient's CA-125 that on that blue is when they're on the treatment for up to about a year or so, they're under control. And then at some point you see progression, you see this sort of resistance emergence. The other issue that we have is toxicity. So PARP inhibitors have some side effects, and some of those aren't pleasant for women. They're also quite expensive. So a thing that we're seeing more and more in the US right now is financial toxicity. So like a treatment literally being stopped because the patient can't afford to pay the copay. So what you can see here, this toxicity, though, is being dose modulated. You can see that the blue level is going down over a period of time. But this patient is so far still responding. So what we were wanting to do was build a model that could try and understand PARP inhibitor dynamics. And ideally, we were thinking we'd come up with some adaptive approach to, one, reduce toxicity, and two, reduce the amount of drug that the patient has to take. That was our original motivation going into this. And you'll see that it wasn't as straightforward as we first thought. So I'm going to show you how this model developed over the course of three different steps and three different models. But essentially, you're going to see at each point, we build the model and we calibrate it with some initial data, and then we validate it by predicting different data at each time point. So just so you kind of understand a little bit about how PARP inhibitors work, they essentially mess with the machinery that repairs DNA damage. So during cell division, if the PARP inhibitor has been instigated, it stalls the replication forks, and the cell will go into arrest. And then depending on the extent of that damage, the cells can either recover, repair that, or die. And so the traditional sort of sensitive resistant model doesn't make any sense here, because cells are either proliferating or arrested or dead. We can explicitly include sort of resistant population if we want, but that would be, in addition, because the sensitivity of the population isn't great. It's more like lack of growth versus death due to drug. It's more like inhibition of growth. So anyway, the model that we came up with initially, first of all, let me explain that we used some very simple sort of 2D cell culture data. And so this shows over time the kind of percent confluence in that population from a number of replicates. And so you can see that you get kind of growth under the drug, some sort of saturating behavior, then it starts to drop again. So what's important there is you're growing under the drug. So the drug isn't immediate in its impact on those cells, it takes a little bit of time. And then when it starts to hurt those cells, it's also not immediate in its impact. And so in the paper, we kind of discuss how we ended up concluding on this model, but essentially it was the simplest model we could come up with. And if you look at those equations, I know they're a bit small, but I don't know how big your screen is there. But you can see it's a generalized logistic growth approach that we're using. And the reason for that is because that seemed to fit the dynamics better than just your classic logistic. Anyway, what's crucial about that is that I take this very simple model of this proliferating and arrested fraction, and I try and fit it to this data. And what you can see with that orange arrow is that we don't really capture the growth under drug that well. We just can't really fit it as well as getting the kind of response under drug. So we're clearly missing something. And so what we kind of, as we read a bit more about the literature, we thought maybe it's a case of that it isn't just a single sort of transition to that arrested state, but it actually takes multiple steps to achieve that arrested state. And so here we kind of implemented a kind of multiple hit model. So essentially saying that it can still undergo divisions when it's first been treated by the drug, but after it gets treated for some extended period of time, that's like receiving multiple hits. And so what we realized was that essentially between 2 and 3 divisions that were allowed under drug were more or less matching what we saw in the experimental data. Now you can see our blue curve does quite a good job of matching the experimental data. And obviously I'm showing you here the different populations because we have our arrested cells in purple, and then there's the shades of green are those different hits, if you like. So, okay, we've fit our model. Let's now make some predictions with it. And so one of the first things we were interested in was, well, what would happen if we stopped the treatment, if we only gave it for a partial period of time? Because again, we were interested in thinking about switching treatment on and off. So let's see how it captures that behavior. So you see the fit on the left, and on the right, when we test it, that's what we're testing it against. This is what the model does. So it doesn't do too bad a job of fitting the response on treatment, but once we stop treatment, our model rebounds too quickly. It kind of regrows too fast compared to what we actually see in the experimental data. So again, we go back and we're going to try and modify this. And so one of those sort of terms there that we want to manipulate was this idea of how long does it take for it to repair. And so the beta in this model. So in our original fits, obviously we hadn't stopped the treatment. It was just on treatment. And so now this is the first time that we're actually stopping treatment. So we actually have to think about repair. And so we went in and played with a whole bunch of different combinations of different models, varying different parameters to try and capture those dynamics as simply as we could. And you're not meant to be able to see the details here, really, except to say that this is what we ended up concluding on. And so we kind of added a little bit more complexity, but also simplified it in a different way too. And so one of the simplifications was essentially, rather than making multiple steps to that sort of drug impact, we now have this sort of alpha term, which is going to, like, that transition, instead of it being sort of a binary term, is there's an alpha rate there. Anyway, we can take that model now and we can fit it. And what we see is that when we do our testing this time, that we get a very nice capture of those when we stop treatment dynamics in the testing. And so that's us feeling, okay, we're doing a pretty good job now of capturing the on and off treatment dynamics with this model. What happens if we, I don't know if that's someone giving me a question. I don't know, I can't see. Is someone asking a question there? Hello?
No, I didn't.
Okay,
So
sorry.
just go ahead. Yeah, thank you.
So anyway, as I was saying, we can do a better job now of fitting that. Okay, so our other interest, of course, was what happens if we sort of manipulate some other aspects of the system. So in this case, what happens if we modulate the dose, or if we start with a different initial fraction? Anyway, our final model that we came up with is this one in model 4. And you can see we've now collapsed it just to 2 populations, and we added this phi. And you can see the phi means we don't have to have this intermediate state where we have a 2-step model for the hits. Anyway, one of the things that we observed in the ovarian cell line data was that if you change the initial number of cells, then you get different types of response dynamics. And so one of the things you can see here is this is 20% starting with a smaller confluence, and that's the dynamics we get. And if we try and fit that, our sort of response dynamic, we get way more cells than we're actually seeing in the dish. It just doesn't match. So that the prediction there just doesn't work. So there's something that we're missing. And so our conclusion is that our kind of assumption of a linear dose response, I should say this isn't initial conditions, it's a different dose, it's 20% the original dose, sorry. So our initial dose then, being significantly different, is way over predicting the reality that we observe. And so what we found was that we actually had to have a nonlinear dose response. And by basically looking at different fixed doses on this population, we were able to infer this nonlinear dose response. And so you can see that now with this 20% dose, we can match it way better, provided we have this nonlinear dose response function D, which essentially is a sort of, curved shape like that. So then finally, we've got our model that can match a different dose. It can match a treatment break. Now, the question is, what happens if we play with the amount of cells that are in the system? So if we have a high density population or a low density population, and playing with the intermittent therapy, so switching the treatment off with a lower dose or switching the treatment off with a higher dose. And what you can see is that we're able to essentially match all of those dynamics really nicely with this final model. And so again, all we did was fit to the initial population with that single high dose treatment, and then we predict all these others, and it seems to predict very well. So now that we've got our sort of fitted model, the purpose of all of this was to then say, okay, can we actually do a good job of trying to come up with a different dosing strategy for these patients? And so there was two strategies that we were looking at, and this is sort of based loosely on Bob's original adaptive therapy trial, or animal work that he did, where he has what he calls AT1 and AT2. And AT1 is essentially a dose modulation strategy, and AT2 is a treatment holiday or dose skipping strategy. So AT1 is really looking at, if the tumor, like depending on its response under treatment, you either decrease the dose or increase the dose. Whereas the skipping strategy is, of course, depending on that response, the shrinkage, you'll stop the treatment or restart it. And so when we tried those two strategies in our model, what we interestingly saw here was that dose skipping or treatment holiday or treatment breaks fails. Essentially, what you can see here is multiple pulses. This is in the bottom panel. The blue line is the overall burden. The green is our sort of proliferating fraction, and our purple dashed line is our arrested fraction. Anyway, what you see is that essentially what the system's doing is it's repairing itself in those treatment breaks, which leads to this surge in growth even when you apply that next therapy. And so that's suggesting, in fact, that dose skipping or treatment breaks would be bad for PARP inhibitors. It's not a good idea. And in fact, dose modulation, as we call AT1, would do way better potentially. And so that's in the AT1 modulation figure. You can see that we keep this population under control by modulating the dose way better than we did with this sort of treatment break strategy. And for some time, we've been trying to do adaptive therapy in an animal model with PARP inhibitors in ovarian cancer. And we were scratching our heads about why it wasn't working. And so now this simple cell line data had sort of revealed to us the core problem. And that is the repair machinery kicks in as soon as you take a treatment break. And so if we compare, these are animal experiments, if you compare continuous treatment, which is the yellow line here on that graph on the top right, and you compare that with the dose skipping, which is the gray line, you can see that continuous therapy actually does better than the dose skipping. But interestingly, our dose modulation therapy does just as well as continuous. And of course, the big difference here is the amount of drug. So in both these cases, the dose skipping and dose modulation, you end up still significantly less drug than the continuous therapy. So in conclusion, in summary, we've identified a complex multi-hit treatment dynamics that seems to occur with these PARP inhibitors. Crucially, dose modulation is preferential to dose skipping, especially with these types of DNA damage agents. And we now have proposed this treatment, novel adaptive treatment protocol. This paper has subsequently been published in Cell Systems. And this little sort of cartoon schematic is really the strategy that we're suggesting. So after chemo, our proposal is that they get this sort of Dmax, maximum treatment of the PARP inhibitor. And then we, depending on, of course, the response, but since you're already in this probably control zone, you switch to this minimum dose. And then we're looking at those growth dynamics. And as it starts to come back up, that's going to flip on to the max treatment again. And then potentially we can control this for far longer with less drug and less toxicity. So that's my conclusions, and this work was all driven by a very talented PhD student, Maxi Strobel, with help from a whole host of folks. The experimental work he also did himself. He's now a postdoc in Jacob Scott's lab in Cleveland Clinic. And he also had help, of course, from Mehdi Damaghi as an experimentalist, and help from Philip Maney and everyone else you see here. And then just to conclude, I wanted to give a little shout out for our sort of community pages, mathematicaloncology.org. If you're not aware of it, you've not seen it, then I don't know where you've been, because it's a really cool place. We even have a cool video series interview from Thomas Hillen, who's in the audience. I heard his voice. There's all sorts of artwork and resources and data sets and links to numerous papers of the week through our weekly newsletter. And this has really turned into a really nice community project. We started it, but it's definitely a whole host of people who are helping drive it forward. So thanks for listening, and hopefully you enjoyed that little sneak peek into our latest results.
Great job. So let's
thanks, Sandy, for a beautiful talk. This is Kathleen Wilkie from Toronto here.
Hi there.
I was wondering about the D of T function, the nonlinear dose response function. So it seems like the results will depend on this function a lot. And I was just wondering how you sort of determined the shape of it, and if it is at all determinable from the limited experiments that you had.
Yeah, the details of how we did that in the paper, but the truth is it's a bit of a fudge, in the sense what we tried to do was look at different doses, calculate the best response fit for that dose, and then be able to essentially calculate a point for each line, for each different dose. We got a point on the line, and then we generated a function that kind of went through those points. So it's a bit of a fudge, but that's the best that we could do with the data that we had. But there's logic to what it's suggesting, which is essentially that, you know, there's a kind of lower dose isn't as responsive as higher dose, but there's a higher dose that saturates, you know, so it's like a kind of increasing function there.
Any other questions? So let's thank our speaker again.